Welcome to the thrilling world of neuromuscular blockers, where muscles go on vacation and anesthesiologists pretend this is entirely routine. These drugs do not provide anesthesia or pain relief. They simply paralyze skeletal muscle, which is wonderful until someone confuses silence with comfort. We group them into depolarizing and non-depolarizing blockers because medicine loves making simple things sound like a tax form. The main depolarizing drug in the operating room is succinylcholine, the dramatic one-liner of paralysis. Succinylcholine acts fast, usually within 30 to 60 seconds, and wears off quickly, which makes it useful for rapid sequence intubation. Key downsides are that it can cause hyperkalemia, malignant hyperthermia in susceptible patients, bradycardia, myalgias, increased intraocular pressure, and a brief existential crisis for the team. Avoid succinylcholine in patients with burns, major crush injury, neuromuscular disease, prolonged immobilization, or known or suspected susceptibility to malignant hyperthermia. There is no true reversal agent for succinylcholine. The reversal is basically time plus supportive care, which is not the most glamorous antidote. Now for the non-depolarizing blockers, the crowd that politely shuts off acetylcholine receptors and quietly ruins everybody's ability to move. Rocuronium is a commonly used neuromuscular blocker with rapid onset at higher doses and a pretty reliable intubating profile. Rocuronium lasts longer than succinylcholine, making it useful for intubation and ongoing paralysis, but less charming if you need fast, spontaneous recovery. Rocuronium can be reversed with sugammadex or, less elegantly, with neostigmine if recovery is adequate. Sugammadex is the celebrity reversal agent for rocuronium and vecuronium. It wraps the drug in a molecular hug and drags it out of circulation. Sugammadex works rapidly and is especially useful for profound blockade, but it can be expensive, and medicine still enjoys making good things inconvenient. Important warnings for sugammadex include possible bradycardia, rare hypersensitivity, and reduced effectiveness of hormonal contraception afterward, because even anesthesia has consequences. Vecuronium is another neuromuscular blocker, a bit less flashy than rocuronium, with intermediate duration and good operating room reliability. Vecuronium has minimal cardiovascular effects, which is anesthesia code for it usually behaves itself. Like rocuronium, vecuronium can be reversed with sugammadex or with neostigmine when there is some spontaneous recovery already present. Pancuronium is the older, longer-acting aminosteroid blocker, the resident who still thinks it is 1985. Pancuronium can increase heart rate and blood pressure because it has vagolytic effects, so it is not the first choice when subtlety is desired. Its long duration makes pancuronium useful in select situations, but less so when you want patients to wake up before the next fiscal quarter. Reversal of pancuronium is usually with neostigmine and glycopyrrolate, or sometimes sugammadex in some settings where available and appropriate. Atracurium is a benzylisoquinolinium blocker with intermediate duration and the special talent of breaking itself down by Hofmann elimination. That means atracurium is useful when organ dysfunction makes everyone nervous, because it is less dependent on kidney or liver clearance. Atracurium can release histamine, especially at higher doses, causing flushing, bronchospasm, or hypotension, as if it needed more personality. Atracurium is reversed with neostigmine, not sugammadex, because sugammadex is selective and does not rescue everything in the neuromuscular aisle. Cisatracurium is the more refined sibling of atracurium, with less histamine release and very reliable use in OR and ICU practice. Cisatracurium also undergoes Hofmann elimination, making it a favorite in patients with renal or hepatic impairment. Like atracurium, cisatracurium is reversed with neostigmine and glycopyrrolate when recovery is present enough to permit polite competition at the receptor level. Final takeaway: succinylcholine is the fast depolarizer with no true reversal. Rocuronium and vecuronium can be reversed with sugammadex. The older agents such as pancuronium, atracurium, and cisatracurium are usually reversed with neostigmine because even paralysis eventually needs an exit plan.